Antianginal agents. Angina, again, is chest pain. There's different types of angina. There's stable angina. Stable angina occurs with activity. So let's say you're climbing stairs and you get chest pain. Once you stop climbing the chairs and rest, it goes away. That is stable. So it comes with activity, but once we stop the activity and rest for a minute, it goes away. As opposed to unstable angina, this does not go away with rest. In fact, it can start to occur with rest. So episodes of ischemia occur even at rest. Those are the classic types of angina. There's a third type that's not as common but does occur. It's called Prinzmetal angina. Prinzmetal is spelled P-R-I-N-Z as in zebra, M-E-T-A-L. Prinzmetal angina. This angina is actually caused by vasospasm in the blood vessels of the heart. This can be, some people are just more prone to it, and they can get this type of angina with extreme weather changes, stress, smoking. Other causes of Prinzmetal angina is cocaine use, illicit drug use, which cocaine is the one that's most commonly associated with it. But just because they get Prinzmetal doesn't mean they're out snorting coke. There's definitely people that are more prone to it for different reasons, but that snorting cocaine can, or you know, you can snort it, or I guess smoke it, whatever it is that somebody does with it, can cause Prinzmetal angina. And we'll talk about how to treat that. The classic anginas, which is your stable and unstable, we'll talk about that primarily. Treatment of angina. So what do we do to treat it? So let's think about first line of treatment. What do you think the first line of treatment would be? We've talked about this with hypertension. We talked about it with heart failure. It's non-pharmacological intervention, non-pharmacological treatments, or lifestyle modifications. First thing we want to do, avoid smoking, right? So just stop smoking. Try to avoid those extreme weather changes and strenuous, stressful, activities. And then reduce factors for coronary artery disease, which, because coronary artery disease obviously is related here. Things that we can do to reduce coronary artery disease: stop smoking again. Low-fat diet, exercise. We got to be careful with exercise. We need guidance with the exercise. Make sure that you talk to your doctor and get on a program that is suitable for you, or for your patient. Let them know that. The medications that we use for angina, there's three primarily anyways. Number one, the most common, the one that we use for right now chest pain, is nitrates. Now, we can use nitrates as maintenance, and we'll talk about that because there's different types of nitrates, but you definitely go to nitrates for right now. If I need intervention right this second because I'm having chest pain, I'm going to do a nitrate. Beta blockers we use as well, and these are a maintenance medicine. And then calcium channel blockers. Those are the classic ones. Now, the calcium channel blocker we can use for our classic angina, the stable and unstable angina, but we can also use that one for Prinzmetal. It's usually the go-to for Prinzmetal angina. All right, let's talk about nitrates first, since they're the ones that are most commonly associated with angina. These act directly on the smooth muscles to dilate the artery. So they're vasodilators, and we've talked a little bit about vasodilators already. These are indicated for angina. So again, chest pain. Anytime somebody comes in with chest pain or complains of chest pain in the hospital, we usually go to nitroglycerin. It's in the hospital, a lot of times it's in the little brown vial. This has to be protected by light. We talked about that a little bit with the first PowerPoint. You know, proper storage. These need to be stored in a brown container, or a container that doesn't allow light through it, and protect it from light. And then also look at the expiration date. These things, it's classic for people to carry these things around forever, and then when they finally need it, they take it, but it's not getting any relief because it's expired. It's very common for these to be expired, and you'll have people come in with chest pain. I've already taken my 3 nitro and I still have chest pain. And you look at their vial and you're like, well, this is 2 years expired. Of course you're getting nothing from these. So we'll try our nitro that is not expired in the hospital. Hopefully, anyways, at least you've checked to make sure it's not expired. So again, that's our indication. Treatment of angina. Isosorbide, whether it's mononitrate or dinitrate, those are longer acting. Nitroglycerin acts right this second. You put it under your tongue primarily. However, you can certainly give nitro IV. You can give nitro topically. There's different ways to give nitro. In the hospital, a lot of times you'll go to that sublingual. Did I say sub-Q the first time? I apologize. Sublingual. We give it sublingual. A lot of times you'll go to that pill or the spray sublingually, and you'll go from there. If you keep going, usually it's for 3 doses of those sublingual ones, until they have 0 pain. So if you give them okay, I got chest pain, it's a 7, and then you give them a pill and they're like, okay, well now it's a 5, and then you give them another pill. Okay, now it's gone. So it's gone. We're not going to give them that 3rd pill. If it continues though, oh, now it's a 2, we give them that 3rd pill. If it continues, then we just consult with the doc and see what they want to do. They may at that point put them on a nitroglycerin ointment, which is like a topical nitroglycerin. You put it on this piece of this specialized paper, and you place it over there, usually on the chest or back or something. Sometimes they'll go to that. Sometimes they'll go to an IV. It just depends on what's going on with the patient, right? We got to look at the patient and see risk benefits of everything, and what is best for them at that time. Whereas isosorbide is long acting. That one you do not take. It is a nitrate, but you do not take it for right now chest pain. It is not a right now life-saving chest pain medication. Nitro is. Adverse effects. You're opening up the vessels quickly, right? It's a vasodilator, so it's going to work directly on those vessels, and it's going to open them up right now. So by it, it's going to cause headache, hypotension, and tachycardia, right? Those are the things that you can just expect to see those. So we're going to assess for blood pressure before we give it. We're going to assess for tachycardia. And if the tachycardia is out of control, we're going to talk to the doc before we give it. If blood pressure's low, you know, certainly below 100, I'm worried. Certainly below 90, I'm very worried before I give nitro. So if I've checked blood pressure and it's below 100, I'm talking to the doc, say, hey, what do you want to do with this? And just keep that in mind. Other adverse effects, people can become tolerant of this. This is one of those medicines where people, if they take it enough for a long period of time, they'll need more and more of it to work, and then eventually it just doesn't seem to work as well. You can also, of course, with that hypotension, get the dizziness, the flushing, and those types of things. Contraindication. So, of course, if they've got severe hypotension, you're not going to give it. If they've got head trauma or cerebral hemorrhage, we're not going to give it. We need to keep that cerebral perfusion as best we can. And if they are allergic to it, or if they've had erectile dysfunction medications, we're not going to give it. Be careful in people with hepatic or renal disease. And again, if they're hypotensive, if it's less than 100, I'm not going to tell you that it's not going to be given, but I am definitely getting direction from the doctor on how they want to give it. I certainly, usually less than 90, the doc doesn't want to give it. I get it. It's a risk-benefit thing. And if I'm giving it, I'm making sure the doc's right there with me in case I have to start doing some major stuff with them. Less than 100, I'm getting permission from the doc. Say, hey man, where do you want to go with this? What should we be doing here? And it's really their job to do that risk-benefit analysis and decide what's safe for this patient. Interactions, we talked about erectile dysfunction medications. That's a big interaction. Other antihypertensives and alcohol can also interact with this medicine. Patient teaching. Notify provider if chest pain continues. So again, remember, normally it's 3 doses. So they get chest pain. So if they're going to go home on this medicine, they're going to go home on nitro. You're going to teach them, hey, if you start to feel chest pain, stop what you're doing, relax, and take a nitroglycerin under the tongue. You also teach them, make sure that it's been stored properly. So don't take it out of this funky looking, glass bottle and put it in some pretty, little thing that you think would be nicer to carry around. Just carry it in the exact container it came in. Make sure that it's up to date, that it's not expired. They should feel a tingling sensation under their tongue. Another thing they need to make sure of, obviously we do not want them eating or drinking anything when they're having chest pain, because the possibility of having an MI, if this chest pain turns into a full-out heart attack, they'll need to go immediate intervention, which is, cath, right? So they'll need a cardiac cath, at which point we want as little as possible on their stomach. So they should not eat or drink anything. That said, sometimes, and I've seen this in my practice, think about what the person looks like with heart pain or chest pain. They're kind of grasping at their chest. They're worried to death, right? And when we get chest pain, we get very anxious. When we get anxious, we start breathing heavy. And when we breathe heavy, our mouth dries out. If you've got dry mucosa, this thing ain't going to dissolve under your tongue. So if you've got the pill, if you had the spray, fine. But if you have the pill, it's not going to dissolve on their tongue and it's not going to work. I've given nitro to people before without thinking about that. And I go back 5 minutes later, it ain't working. Okay, good. Here, take another one. Oh, wait, that one never dissolved. So think about that. They may need to take a small sip of water, not drink it, but just kind of get it around their mouth to make sure that their mouth stays wet enough in order to take the nitro. They can take up to 3 doses, and if by the 3rd dose it's still chest pain, they have to call 911. In the hospital, when you're giving it, you don't give more than 3 doses. Now, where I've seen that differ is people that have taken a couple doses. So they come in, I've got chest pain. Have you taken any of your nitro? Yeah, I've taken a couple. The doc may go ahead and give more at the hospital because they may think, well, maybe that nitro is just no good anymore. Let's see if our nitro works. It's possible. I've seen that a couple times. But for the most part, they should not take more than 3 doses. I had a horrible event once of a patient that came in. Unfortunately, they died. They had taken 6 nitro, way more than the recommended dosage, and they had already had some problems with hypotension, and they went ahead and took 6. It's a horrible, sad situation. So do not give more than 3. And make sure you educate them to not take more than 3 when they're at home. Call 911. Don't drink alcohol while taking nitroglycerin. Don't take your ED medications while taking nitroglycerin. Warn them that, look, dude, it's probably going to cause a headache. It's very common. You can treat that with a little bit of acetaminophen, aka Tylenol, as long as you're okay to take acetaminophen. And of course, we're teaching them how to take those sublingual tablets. All right, so some commonly used nitrates and routes of administration. Nitroglycerin, just Nitrostat, good old sublingual nitroglycerin. Most common, that's your immediate action, your immediate relief. That's the one you go to for acute angina. Right now, I need relief angina. That's your nitroglycerin. Nitrostat. Nitroglycerin nitrolingual is your translingual spray. That is also a go-to immediate action medication. You will see that from time to time. Isosorbide, if it says isosorbide, whether it's mononitrate or dinitrate, and again, these have longer action, longer life than the nitroglycerin. And again, the mononitrate actually is a little bit longer than the dinitrate, but it doesn't matter. I don't care that you know that. Just know isosorbide is not an immediate relief medication. That is for maintenance. It is not for I need help right this second. There's different other types of nitroglycerin. Nitrobid is your type topical ointment. That is the type that is it's an ointment that's put on a specialized card. The card it's actually measured in inches. Funny enough, so they'll be like, give 1.5 inches of Nitrobid or give 2 inches of Nitrobid. There's a card, a specialized card that you put that on, and then you put it over, or you place that on like their chest or their back or wherever. It's usually in the upper torso. Anytime you're going to put that on, obviously make sure you're wearing gloves, because that stuff is designed to go right through your, to absorb through the skin. If you were not wearing gloves, you could potentially ingest some of that and cause some big problems for you. And make sure you're wearing gloves when you take it off, and that when you take it off, you wash that site. And then if you need to, so let's say that doc's like, let's do this every 8 hours, fine, great. You're going to take that patch off, wash that site so that you take off any residue that happens to be there, and then you're going to put it in a different location. You're not going to keep using the same location, or you can get some irritation there. Transdermal is just a patch. You can give it IV as well. So there's different ways to give nitroglycerin. Just the most common one is that sublingual nitroglycerin for your immediate reaction. Obviously, nitroglycerin IV is also immediate, but you don't normally start with that. I've never started with that. I've always started with the nitroglycerin sublingual, and we see, is it working? And if it works good enough and take it all away, then we don't have to worry about going any further. Sometimes it works, but just a little bit. So they go from a 10 to like maybe a 6. So it's working. But it took them 3 to get down to a 6. Doc's like, let's hook them up with some Nitro IV. All right. Beta blockers we've talked a lot about in the last section. Primarily, we were discussing hypertension at that point. But we know they also are used for angina and for atrial arrhythmias at time. We know that anytime medication ends in LOL, we know it blocks beta. The medicines that we use for angina are typically metoprolol, propranolol, and nadolol. By looking at those, we know that metoprolol is our selective, nadolol and propranolol are non-selective, so we'd be careful with who? COPD and asthma. Action, again, it blocks the beta receptors, decreasing heart rate, cardiac output. What that does is help decrease the workload of the heart, like we talked about. And why that works for angina is because, well, angina just means part of your heart is not getting enough oxygen, so it's causing pain. When that oxygen is completely cut off, then it starts to die, and that's called an MI, right? So with beta blockers, when we start to have that chest pain because we're having a decrease in oxygen in that part of the heart, if we can decrease the work of the heart doesn't need as much oxygen, so it'll decrease the chest pain. Nitrates actually work the same way. A lot of people think nitrates work by dilating those cardiac vessels, allowing more blood to get through, and that's part of it. But a lot of it is the fact that all the vessels are dilated, causing a decreased workload of the heart. So the heart doesn't have to work as hard to push that blood through, decreasing the oxygen consumption need for the heart, decreasing chest pain ultimately. And again, our indications, angina, you'll see them used also for a cardiac, or I'm sorry, heart attack. There we go. Calcium channel blockers, we talked about these already as well. There's a whole list of them there. Diltiazem and amlodipine are the ones that I've seen the most. However, I've given all of those at one time or another. They inhibit the movement of calcium into the muscle cells, so that's our action. That causes a decreased myocardial contractility and dilation of the vessels or the arteries, and that decreases cardiac workload. And when we decrease cardiac workload, we decrease the amount of oxygen needed by the heart, therefore decreasing the chest pain. And that's what we're using those for as far as this goes, is angina. However, these are also used for Prinz metal angina. We'll see these used for Prinz metal to help relax those vessels and relax that vasospasm. Diuretics, very common medicine. A lot of times the go-to for blood pressure, as far as like first go-to, you'll see ACE inhibitors used as a primary medicine, but also diuretics. But these are also used for edema. Anytime somebody has some edema that we're trying to get rid of, whether it's for heart failure or cirrhosis or renal disease or whatever, some sort of injury, sometimes injuries can cause edema, we'll go to diuretic use. So indications for diuretics, edema, right? That's the big one. Edema associated with heart failure, edema associated with pulmonary edema, cirrhosis, liver disease, renal disease. So edema is the big thing with diuretics, but we also use them for hypertension. If we decrease the amount of fluid in the body, decrease the amount of fluid in our peripheral in our vasculature, we're decreasing blood pressure. So hypertension, we do use them for that. And we also use them sometimes to reduce hyperkalemia, and that's the loop diuretics that we use to decrease hyperkalemia. We'll talk more about that as we get into these. All right, thiazide and thiazide-like diuretics, very common medications. Hydrochlorothiazide, a lot of times it can be given by itself or it can be attached to another medicine. It's abbreviated HCTZ, so anytime you see HCTZ, know it's hydrochlorothiazide. It's a thiazide diuretic. These work in the distal tubule. Don't get too crazy with the thiazide likes. You'll see those from time to time. Hydrochlorothiazide, I'm telling you right now, is the one that you're most going to see. Again, promotes water excretion in the distal tubule. So if we look at a nephron and how it works, it pulls sodium and it cleans the blood, right, and pulls out waste. Part of that is it pulls out sodium. The way the diuretic is going to work is going to pull out the sodium, and your water is going to follow that, and then you're going to urinate the sodium and the water. Unfortunately, potassium also is pulled out at that point in the tubule, and your potassium is going to stay out. It's not going to be reabsorbed. Normally, when your sodium levels go low, your potassium levels go high to compensate, and vice versa. However, with diuretic use, with thiazide and loop diuretic use, it's different, because that reabsorption is blocked off before it's available to be reabsorbed, and then it's just urinated out. So hypokalemia and hyponatremia are common electrolyte imbalances associated with thiazide and loop diuretics. This one works in the distal tubule. We use this for hypertension primarily. However, we will see it used for edema as well. But you'll see this attached to hypertension medicines all the time. But you can certainly use it for edema. It's a less effective medicine than loop diuretics, which is good sometimes, because loop diuretics can be way too effective and cause too much diuresis. So it's more of a mild diuretic. But we certainly need to take it serious and make sure that we're watching for dehydration, watching for electrolyte imbalances. Adverse effects, we talked about hypokalemia and hyponatremia, right? We're worried about that because we're urinating the sodium and urinating the potassium. Hypokalemia probably more so than hyponatremia, just for the simple fact that, well, here in America, we're huge fans of salt. Basically, American food is just different colors and shapes of salt, right? I'll take a hamburger shaped block of salt and some French fry block of salt, and you know, do you have any of that liquid salt with a little bit of potato and bacon salt in it, right? I mean, it's all salt, so we don't usually have a problem getting salt. But potassium, on the other hand, we don't necessarily always get enough of that. We usually get enough of it fine, but if we're spilling out, we may not get enough of it to make up for that. Whereas the salt, we usually have no problem. But you'll certainly check it, you know, keep an eye on that. You'll check your electrolytes. So anytime you're going to give a diuretic, just check electrolytes real quick, make sure everything's okay. Potassium and sodium are the ones that are most commonly affected. It can also affect magnesium. It can cause magnesium to go low and calcium to go high. Another thing that can potentially go high with this that you may not think of immediately or associate with it is hyperglycemia. It can actually cause your blood sugars to go a little bit high. It's associated potentially with high lipids, and it is associated with hyperuricemia, so uric acid. What we're concerned about there with hyperuricemia is in people with gout. We certainly don't want to exacerbate that and make that worse, and that's a potential problem with diazide and even loop diuretics. So just to recap, because that's a lot, let's try to package that up a little neater. Adverse effects, hypokalemia and hyponatremia as far as electrolytes are concerned. Those are two of the more common. You can also have some magnesemia. I'm going to say that wrong. Magnesium's low. Let's go with that. As far as hyper is concerned, you can have some hyperglycemia, some hypercalcemia, hyperuricemia, and hyperlipidemia. Those are all potentials. With that, think about what we're giving it for. What's our primary indication? Hypertension with these medicines. So it's potential that you could cause some hypotension, right? If we're giving them for hypertension, we could cause hypotension. So we're going to watch out for that. Contraindications. You're going to check for sulfa allergies here. If they're allergic to sulfa drugs, then they shouldn't get diazide drugs because they're chemically related. So we're looking at that cross sensitivity like we were talking about in the last, with the first PowerPoint, right? So contraindicated with sulfa allergies. Obviously, if they're allergic to thiazides, that's contraindication. But also look for allergy to sulfa drugs. Be careful in people with renal disease, even liver disease, because of the way these are processed could be a problem. The big thing we want to be careful about is our electrolytes. We want to look at those electrolytes because that can turn into a contraindication real quick, right? If they have hypokalemia, we ain't wanting to give these. You like how I said that? Ain't wanting? Because I'm an English major, as you can tell. You ain't wanting to give thiazides if they got the hypokalemia. So look at that. Look at your electrolytes. Make sure they're okay. If they've got diabetes, we got to tell them, hey, look, man, you got to check your blood sugars a little closer with these medicines because of the fact that these can affect your blood sugar. So we want to make sure we're just being a little more cautious with that. People with gout, if they got gout, we got to be very careful because we can increase uric acid, increase that inflammation and those exacerbations in gout. So we don't, we want to make sure we're real careful with that. Interactions. NSAIDs like to interact with lots of things. And of course, it'll interact with other antihypertensives, can cause further decrease in blood pressure. Patient teaching. So think about this. It's a diuretic. And what's the nature of a diuretic? To pee, right? To make them pee more. So when would they take these? When's the best time to take something that's going to make you pee more? And that's in the morning, right? If they have to take them a few times through the day, make sure that they don't take them at night before they go to bed, right? So if they have to take it twice a day, they're going to take one in the morning. They're going to take one probably maybe early evening around dinner time, depending on when they eat dinner, right? If you eat dinner normally around 5, that's probably a good time. So early evening is a good time. If they take it at night, they're going to be up peeing all night long, and then that is going to affect their compliance. We're going to teach them about potassium foods and making sure they get enough high potassium foods. So bananas, citrus foods, what else? Navy beans. Trying to think of all that stuff. I always think the classics are bananas and citrus, spinach, avocados, maybe. That sounds about right. Cantaloupe. Yeah, I know that. Cantaloupe. Tomatoes, actually. Potatoes. I think it's the potato skin. Well, that's because, you know, they got potato appeal. Anyways, those types of things. So just look up foods high in potassium. We're going to encourage that. And another thing that people think, it seems kind of counterintuitive sometimes, but when you really stop to think about it, it makes sense. We want to encourage them to drink water. Not necessarily get more than what they normally get, but to maintain water intake, because they may think, oh gosh, I got to take this to pee, so I should make sure I limit how much fluid I get. Now, if the doctor puts you on a limit, which sometimes occurs, so the doc puts them on a 2-liter limit, fine. We're still going to educate them to make sure they get that 2 liters or close to it every day, right? Because if they're like, oh my God, I'm on a fluid limitation, I better not drink any fluid, so they get themselves in trouble real quick. So again, encourage that fluid intake. Water is best. It's really, you know, caffeine is going to exacerbate diureses. Alcohol will too, can dry them out. Water is probably the best. But anyways, we do not want to decrease fluid intake, okay? We want to maintain adequate fluid intake. We're not telling them to increase what they're normally taking, but we're telling them to maintain, because a lot of times people are going to see this like, oh gosh, I'm on a diuretic, and they're going to stop drinking fluids very much. They're going to at least draw back, you know, very seriously, and that can lead to some serious consequences. Loop diuretics, a very common diuretic, especially in the hospital, but you'll see them. People can be on these, you know, daily as well as a maintenance type of thing. Furosemide and torsemide are the most common. Bumetanide is another one. The most common ones are the ones that you really need to concern yourself with is furosemide and torsemide. Now again, we're blocking that pump. We're working on the tubule. We're blocking that chloride pump, but this time we're doing it in the loop of Henle, which is going to cause pretty extensive diureses. These are far more effective at diureses than your thiazide or your potassium sparing. So we use these for those types of situations when we need some pretty rapid diureses. Indications, again, choice. It's the drug of choice for rapid diureses. You'll see that needed a lot of times with pulmonary edema or acute heart failure. This is the go-to. Some cautions here. A lot of times when we need rapid diureses, what route do you think we need to go? Think about what route is the quickest. If we go back to our first PowerPoint, we learned that absorption is most affected by route, right? And the quickest route is IV. So you're going to give this IV. If you go back to our little days in lab, we learned that furosemide is to be given as a slow IV push. Usually, I have seen, always check your protocols. I've seen protocols that say 20 milligrams a minute. Fine. I'm going to tell you right now, I prefer 10. It's safer. The problem with giving Lasix or furosemide too quickly is it can cause oto and nephrotoxicity. The ototoxicity is normally reversible, but not always. That doesn't mean it will always be reversible. You can cause irreversible hearing damage to somebody by pushing furosemide too quickly. A lot of times it is reversible, but don't expect that. Okay, I have unfortunately seen people push it way too quick. The doc ordered 40 milligrams. They went in there and pushed that thing in less than 10 seconds, and I freaked out. I like 10 per minute. It's safer. It just is safer to me. 20 per minute, if that's what your protocol says, fine. But dude, let's just be safe. Give it 10 per minute. Other indications, hypertension. You will see this sometimes given for hypertension. And then you'll just see it for maintenance of heart failure or cirrhosis, right? So it's used for rapid diureses for those types of situations, but then you'll also see it used for maintenance diureses for those situations as well. So they may be taking it PO. It's not always given IV. In fact, it's very commonly given PO. When I was talking earlier about trying to reduce exacerbations or full exacerbations of heart failure and keeping people out of the hospital, one way we do that is with PO Lasix or PO furosemide. Lasix is the brand name, furosemide. So whenever I would assess those crackles in the lungs, some patients were very labile heart failure patients, so we put them on a thing called telehealth. Telehealth means we give them a Wi-Fi connected scale and sometimes ECG, and then Wi-Fi connected blood pressure and oxygen monitor. And every day when they wake up, before they urinate or after, I apologize. When they wake up, they go pee. So after they urinate, they jump on the scale and they check their blood pressure and their sometimes an ECG and their oxygen saturation and heart rate. Those metrics go to the computer and I can look at them and go, oh my God, like overnight they had, 2.5 pound weight gain. I know I need to go out and see them, start doing some assessments and determine whether they need to take another Lasix or furosemide. So those are some of the indications that we have. Hit everything. Oh, man. All right. Patient teaching. We want to teach people about potassium, obviously. High potassium foods like we talked about before, avocados, bananas, cantaloupe, what else did I say? Citrus fruits. Be careful with grapefruit, especially if you're taking other medicines like calcium channel blockers and such. Spinach, tomatoes, there's all kinds of stuff. It's high in potassium. Potatoes. With the potatoes, you can either cook them, mash them, or put them in a stew. One of those usually is that's the common way that people use potatoes. They cook them, mash them, stick them in a stew. One of those things. Anyways, so eat potassium-rich foods. Take in the morning. Change position slowly. We're worried about that orthostatic hypotension. Sit on the side of the bed. And discuss your OTC meds with your doctor. All right, potassium-sparing diuretics. So we've talked about thiazide and loop diuretics, and one problem with both of those is they spill a lot of potassium, especially the loop diuretics, your furosemide and torsemide. But thiazide as well, hydrochlorothiazide, can spill potassium and be a problem. If potassium gets too low, that can be life-threatening. So it's pretty important to keep the potassium, at a normal level. Too high can certainly be life-threatening as well. So we have an option. It's potassium-sparing diuretics. It's been common for someone to have, it's usually thiazide. They're on thiazide diuretics because it's a mild diuretic, and so is potassium-sparing diuretic. But it's causing hypokalemia, and they're not able to maintain it with a safe amount of potassium supplements. So what they'll do is they'll switch them to a potassium-sparing diuretic. Spironolactone being the most common. However, I have seen triamterene as well. Spironolactone is probably the most common. I know it is because that's the one that I've given the most. Acts in the collecting tubules to promote sodium and water excretion. Now, so again, before this we've worked up the nephron, right? We've worked in the loop and the distal. Now we're working in the collecting tubule. So the potassium is coming back in. But this will allow, so the potassium's come back in, so now we're retaining the potassium, but it's still going to promote that sodium and water excretion. So we're still going to get diureses. It's not as marked, it's not as rapid, it's not as full as a loop diuretic, but you still usually get a good amount of diureses that we can help with maintaining fluid balance for heart failure and hypertension. On a side note for indications, it is sometimes used for hyperaldosteronism. Sometimes you can get hyperaldosteronism from like a tumor or different reasons. Sometimes this is also used for hyperaldosteronism. Great. We're not going to go crazy in it because it actually it can block aldosterone action. But again, that's just a side note, just so you know. I want you to have that information in case that ever comes up, like on NCLEX or ATI or anything. We're not going to go deep into that right now. We're really going to concern ourselves with hypertension and heart failure. Adverse effects. Well, think about that. If we're sparing potassium, so we're collecting potassium, you could potentially cause hyperkalemia. We may spare too much potassium. So hyperkalemia is associated with this. With it being potentially affecting aldosterone, we can have androgen effects. Androgen effects for men, sexual dysfunction, and gynecomastia. Gynecomastia just means male breast tissue, right? Male breast enlargement. For women, menstrual irregularities. Those are potential adverse effects of potassium-sparing diuretics. Most common, obviously, hyperkalemia and all that comes with hyperkalemia. However, the androgen effects, we have to make sure we look for those. Gynecomastia, menstrual irregularities, sexual dysfunction, even hirsutism. Remember hirsutism, if you can, I believe we covered that in fundamentals, but anyways, that's irregular hair growth. With women is who we're most concerned about a lot of times with that. It's hair growth, facial hair growth. So it would be contraindicated with hyperkalemia. You're always going to check potassium before you give a potassium-sparing diuretic, and if they have high potassium, you ain't going to give it, right? We're going to give something else. Depending on how high that potassium is, we may actually now go to a loop diuretic to try to get rid of that potassium, because that's one thing that we use loop diuretics for. These also can cause some potential renal issues. So if they have acute renal disease, we're not going to give it. Another thing I forgot to mention with loops and thiazides, but are also true with any diuretic you give. Any diuretic you're going to give, if they are anuric, meaning they're not making urine or not releasing urine at all, there's no release of urine, you're never going to give a diuretic. One, if it's a blockage issue, the last thing you want to do is continue to make more urine and fill that bladder up, right? Last thing you want to do is fill the bladder up even more. Then it's going to back up into the ureters and the kidneys, and then it's going to be a big deal. So you're not going to do that. If it's anuria because the kidneys aren't working appropriately, and they've completely stopped making urine, you're not going to give them either, because what's the use? So it's contraindicated in anuria. That is all of the diuretics. Caution in people with diabetes, hyponatremia. We're sparing sodium, so we're going to check that and make sure that the sodium's not too low before we give it. Interactions. Well, the obvious interaction, the one that we should all be thinking about right now, is potassium supplements in potassium-rich foods. This has happened. I've seen it happen, and I've had to contact the doc and talk about it. So I want to make sure I'm warning you about it so that you know. Always watch. When I first started talking about potassium-sparing diuretics, I said one of the common ways that I've seen them given is the thiazide diuretics causing too much potassium spilling. So they switch them to a potassium sparing. When they're on a thiazide diuretics, it's causing the potassium spilling. The first thing they usually try to do is just give them a potassium supplement, but sometimes that don't work. So they don't want to give too much of that potassium supplement, so then they'll switch them to a potassium sparing diuretic. What happens there is sometimes they will forget to DC the potassium supplement. Now, if they've got marked hypokalemia and they switch them to a potassium sparing diuretic and they have them on potassium supplements, I'm going to ask the doc about that, although I know that's probably okay today. But I'm not going to just say it is and just give it. I'm going to check. That way we're all on the same page as to what we need to look for and when we're going to stop these, and basically when we need to do BMPs and check our metabolic panel. Early on, they may say go ahead and do it because we got to bring that potassium up. However, we definitely don't want to keep them that way. And I've certainly seen it where I've like, hey man, you know, I noticed you did this, but the potassium is not too crazy low. Or did you mean to continue the potassium supplement? And they're like, oh no, actually, you know what? I think we're okay. Let's just stop that and see what the potassium sparing diuretic does. And it worked just fine. So just keep that in mind. Potassium supplements interact obviously with potassium sparing diuretics. So if the doc cancels a hydrochlorothiazide or even a loop diuretic, whatever, and puts them on a potassium sparing diuretic for that reason, and they keep them on the supplements, just give a quick call or a quick shout out and say, hey, I just want to make sure we're okay to give this. Other interactions, potentially NSAIDs, can affect the usefulness of these. Also, what other med did we learn about that can cause hyperkalemia? Remember back to our second PowerPoint that we talked about, our second set of notes. That was ACE inhibitors, right? And the RAS medicines. We can potentially cause even further hyperkalemia with those meds. Not to say you won't give them, just to say now I know I really got to watch that potassium. Patient teaching. Well, instead of encouraging potatoes, which usually with those you cook them, mash them, or stick them in a stew. That's the most common way that people eat potatoes. They cook them, which is good. They mash them, which is, I like mashed potatoes, and I like them with the skin on for a few reasons. One, because I think it's tastier, and two, I'm too lazy to take the skins off. Primarily, I'm too lazy to take the skin. It's mostly because I'm too lazy to take the skins off. That's the primary reason. And then stick them in a stew. Dude, I flippin' love potato soup. I know it's not the best thing for you, but if I only have it a couple times a year, it's pretty cool. It's so good. But it's got to have bacon and extra salt, which is cheese in my case. Anyways, I digress. Limit your potassium foods. Limit those high potassium foods. And then we'll want to warn them against other potassium supplements, such as fake salts. You can get fake salt, right? I think it's called new salt. I think that's right. At least it used to be. All it is potassium. So for people that have heart failure or that have hypertension, whatever, the doc says you need to limit your salt, go down to a 2-gram sodium diet, they may try some new salt. It's just potassium. Obviously, they're going to be at higher risk for hyperkalemia if they're taking that on top of a potassium-sparing diuretic. And if they're taking potassium supplements, they need to stop those as well. We need to talk to the doc and say, okay, what do you want to do with these potassium supplements? Last diuretic we're going to talk about is your osmotic diuretic. Now, osmotic diuretic or mannitol, these are used for that elevated intracranial pressure. There's other uses for them too. Sometimes we use them to actually elevate intraocular pressure for certain reasons. But primarily they're used to elevate intracranial, used to decrease that intracranial pressure that's caused by cerebral edema. So if you've got cerebral edema, we need to get that water off of there as soon as possible, and the quickest way to do it is with mannitol. Mannitol is massive diuresis. We only use it for these types of situations, these emergent situations, because it causes such massive diuresis, and it can actually throw someone into pulmonary edema and other bad things and heart failure. Even though we usually associate diuresis with, encouraging diuresis with helping with heart failure and pulmonary edema, this can actually cause it if we're not very careful with it. So we don't use these, but in certain specific situations. Another situation you may see these used in is to prevent kidney failure. So we want to continue to, so that the kidneys are still working, but they're circling. They're not doing great. We may encourage perfusion, encourage diureses with these to help keep the kidneys going. However, once the kidneys get to a certain level, now it becomes counterproductive. The risks far outweigh the benefits, and then they'll be pulled off. In other words, if you're on mannitol, you're in the ICU or the ER, most primarily the ICU. You have to be very well watched, right? We've got to be very careful with these guys. The action is just to, it works, this one works in the proximal tubule. It causes sodium and water excretion, just like any other diuretic. Mannitol, you may be familiar with. If you read ingredients in your foods and candies, you may have seen mannitol before. It's a lot of times used as a sugar substitute. So if you're chewing gum, like most common place I've seen it is in gum. If you chew gum, especially the sugar-free gums, those a lot of times will have mannitol, because mannitol is just a sugar. It's a sugar that causes massive diureses when given IV. However, when given PO, you can absorb some of that, and you may get some diureses, but not really. It's mostly the GI tract just flushes it out. But when given IV, it actually becomes a very potent medication. So you've probably taken mannitol, or some of you may be taking it right now. Adverse effects. Well, I told you, we got to watch these guys. You got to be real careful with these guys, because we can actually throw them into pulmonary edema. We can throw them into heart failure. We take this medicine to help prevent full kidney failure in people that are circling, right? To help prevent that kidney injury. However, it can totally cause kidney injury if we're not very careful with it. So these have to be watched. They have to be, we got to really watch their BMPs, or actually you're going to probably do a CMED on these. We're going to really, really watch that information. We're going to do INOs, strict INOs on these guys. It can cause heart failure, cause pulmonary edema. Kidney failure can cause, of course, fluid and electrolyte imbalances. It'd be contraindicated if they have current pulmonary edema. And then be careful with people, again. So we give it to help protect the kidneys in times of damage. But if they already have renal impairment, depending on where they're at, we'd be very careful, or at least be completely contraindicated. So it's going to be a risk-benefit thing. Let your doctor make that determination. Interactions. These can interact with lithium and antihypertensives. Antihypertensives make sense because we're going to further potentiate the hypotension. Lithium, unfortunately, so here's how diuretics, really all diuretics can potentially interact with lithium, to be honest, because we are spilling sodium. Normally, we get enough sodium in our diet to keep us stable. However, any medicine that can cause low sodium is going to interact with lithium, because lithium is a salt. So this can go for loop diuretics, thiazide, potentially, even though it's not as common. And certainly, though, osmotic diuretics, where you have massive amounts of diureses and sodium loss. You can, your body is going to hold on to any salt that it can, right? Whatever salt it can hold on to, it's going to hold on to. Lithium being a salt, it's going to hold on to salt. Lithium is a narrow therapeutic range medication. You can get into toxicity really fast. So that's how it interacts with that. As far as patient teaching is concerned, it's really more nursing considerations. You can kind of scratch out patient teaching and put nursing considerations, because these guys, they're in your ICU. You're going to be strictly watching them. You're going to be watching their INO, be watching their weights. You're going to be watching their kidney function and electrolyte function. You're really monitoring them. They have to be monitored. You're going to look for signs of dehydration, and you're going to look for signs of edema, right? Because we can go crazy with these, and they can cause some organ problems, and now we may start having heart failure and kidney failure. We're really going to watch these guys. All right, so let's talk about lipid-lowering agents. First thing we're going to talk about is coronary artery disease. Lipid-lowering agents, obviously, we use for hyperlipidemia or high cholesterol, and that puts us at risk. High cholesterol puts us at risk for coronary artery disease. That's one of the risk factors there, and that's one of the big things we're trying to help with these medications. So let's talk about coronary artery disease a little bit. Obviously, coronary artery disease is when our coronary arteries can get a blockage in them, potentially causing there'd be enough of a blockage to potentially cause a myocardial infarction. Some things put us at risk for that. One is just genetics. Genetics is always a big risk. Some people are just more genetically predisposed to coronary artery disease than others. And that's really true for a lot of different illnesses and disease processes. And this is no different. And that's non-modifiable, obviously. There's nothing you can do about genetics. It is what it is. Another non-modifiable is age. Obviously, there's nothing you can do about age. As we get older, we're at higher risk. Gender is another risk factor. That is, men are at higher risk. However, studies have shown once a woman is postmenopausal, that risk almost evens out. So at least we'll say women can start to catch up with men at that point for the risk factor. Some things that, other things, hypertension is another risk factor. Diabetes is a risk factor. There's some, obviously, some modifiable or lifestyle choices that put us at higher risk. Cigarette smoking is a big one. But sedentary lifestyle is just as big. So getting people out moving is a big deal to help them to decrease their risk. High stress levels puts us at higher risk for coronary artery disease. And obesity. Those are the risk factors there. And then I already mentioned hyperlipidemia there at the beginning. So types of lipids, we have LDLs. They also call them the bad cholesterols. You've probably heard that before. That's your low density lipoproteins. Right now, what they're recommending normal to be about 100 to 129. You may see a few variances on that range, but that's the basic range that we're using. HDLs supposedly are good lipoproteins. They're the high density lipoproteins. We want those usually to be better than 60. That's considered cardioprotective. Triglycerides are another element there that we want to try to limit. We normally want those to be less than 150. So what's our non-pharmacological treatment? Well, when we're talking about hyperlipidemia or high cholesterol, we can always go right to diet, right? So if we can reduce our saturated fats in the diet, that can help us. They usually recommend about less than 30% of caloric intake be total fat. Other things we can do though, get out moving, exercise. Get off the couch. And that can be difficult sometimes, but exercise is a big one. Losing weight and stopping smoking. Right? Those three things can definitely help us with our hyperlipidemia. All right. So one medicine that we do use from time to time is called bile acid sequestrant. I've given it a lot of times. It's been with home health situations or rehab. I don't see it in a hospital as much. Cholestyramine, that's the one that I've given the most. However, colsavelum is another one. Yeah, you'll see there's others as well. What these do, here's the way these work. They actually bind to bile acids. So we got the bile there in our GI. It binds to that and and we flush that out. We obviously get rid of that in our stool. What that does is Bile acids your body uses cholesterol to make those. So if we get rid of bile acids and we need more, the body needs to make more, it'll use up cholesterol. So that's the thought process behind that. So binds to bile acids, and then we use the stored cholesterol that we have to make more bile acids, and that causes that to fall. And we use these for hypercholesterolemia, or high cholesterol. That's our indication. Adverse effects. The most common adverse effects are GI related, so nausea and constipation. This can also affect how we absorb certain vitamins, especially fat-soluble vitamins, and that potentially could be a problem. But those are most common adverse effects. Contraindication, you would not want to take this if you had gallbladder disease, because think about that. I mean, we're causing more bile to be made, so the gallbladder's going to have to work more. If you already have gallbladder disease, you don't want that. And also pancreatitis, you wouldn't want to take these if you had pancreatitis. And then if your intestine isn't working normally anyways, it's probably it's not a total contraindication depending on what's going on there, but we'd certainly be careful with that. These can actually interact with a lot of meds because they can delay absorption or even just totally decrease absorption with a lot of different medicines. So really, it's important to understand, one, that these can affect the absorption of a lot of meds, so they need to be taken separate. So this medicine needs to be taken separate from other medicines, and that's our patient teaching. Take it apart from other meds with an 8-ounce glass of water. It would be preferable to take your other meds first, and then an hour later take this med. So again, you would normally take, let's say the person's on digoxin, warfarin, and hydrochlorothiazide. Those are all definitely affected by this medicine, very common medicines. There's others as well, but let's just go with those for now. So you're on those meds. It would be best for you to take your PO meds now. So let's say it's 9 a.m. You give them to them at 9, and then you wait about an hour for those to be able to be absorbed, for the system to be able to absorb those and start to utilize those, and then take your bile acid sequestrant. If you do it the other way, if you take your bile acid sequestrant first, you would want to wait then about 4 to 6 hours before taking PO meds. That seems to be the range that it won't affect absorption of those meds as much. So again, the goal would be to take your PO meds, take PO pills first, and then take this. This is a PO med, but you would take your other meds, PO meds that you have to take first. So let's say at 9 o'clock, and then you would take this at 10 o'clock. However, if you took this at 9, then we'd have to wait 4 to 6 hours. So we're looking at like what, 1 to 3, somewhere in there, that you would have to wait until you could take your bile acid sequestrant or your cholestyramine. So try to remember. And the mistake I've seen with this med is people don't realize that this med is commonly, it says take with 8 ounces of water. It's commonly a powder, actually. You just take a scoop of the powder, or however much has been prescribed. You put it in water and you stir it. So just think about what that already sets up in someone's mind. They're like, oh, sweet. Here, I can kill 2 birds with 1 stone. Take your pills, wash it down with this medicine here. That's mostly water. Unfortunately, that's actually the worst way to take it because it can block that absorption of a lot of meds. So just be careful that. You will see this from time to time, especially if you do home health. You'll have to educate them. You're not necessarily giving them those meds. Maybe you are, depending on what type of home health you're doing. But at the very least, you're gonna, when you're setting their meds up, you'll let them know, hey, take your pills first, and then about an hour later, take this. If you're in a rehab facility or even the hospital, I mean, I'm not saying you won't see it in the hospital. I just haven't seen it. The places I've seen it have been with home health and rehab. But you'll know when you're getting meds ready, and they have cholestyramine ordered. Go ahead and separate that. Just give them the pills first, and then give them that cholestyramine about an hour later. That's the best practice anyways. HMG-CoA inhibitors. These are the most common of the hyperlipidemia medications. They're fairly well tolerated. And there's some studies out there that actually show that anyone over the age of 50 or 55, depending on what you're believing and what's going on with the patient, that they should, whether they have high cholesterol or not, should be on a statin for cardioprotective reasons. There's some cardiologists that fully endorse that, and there's some cardiologists I've worked with that don't. But statins are very common medicines. You will probably give them every single day of your nursing career that you are having contact with patients, or you will work with them. It's very, very common for patients to be on statins. And that's how you'll recognize these medicines. They end in statin. So atorvastatin, simvastatin, rosuvastatin, lovastatin, pravastatin. I've given all of those. You may know them as Lipitor, Zocor, Crestor, those types of things. But if it ends in statin, you know it's a cholesterol medicine. How these work, they inhibit HMG-CoA, which don't go too crazy in understanding exactly what that is. These are called HMG-CoA inhibitors. Most people refer to them as statins. At the end of the day, when we inhibit that, we decrease our cholesterols. We decrease our LDLs and our triglycerides, and we supposedly increase our HDL levels. That's the goal anyways for these medicines. They're pretty good at decreasing triglycerides. There's another med we'll talk about later that's more focused on triglycerides. So if they have a normal cholesterol panel, but their triglycerides are a little high, they'll probably try another medicine. But these are still pretty good with lowering triglycerides, so you will see that this used for that as well. So again, you will know these because they end in statin. Again, action, lower LDLs and triglycerides, increase HDLs, and that's our indication. High cholesterol, hypertriglycerides, and then like I said in the beginning there, sometimes these are used for cardioprotective or cardiac prevention, or cardiovascular event prevention. So somebody may have a normal cholesterol profile, but they're still on these because their doctor thinks that the research shows that these can be cardioprotective, and that's fine. There's some research out there both ways, but I've seen a lot of cardiologists agree with that, so you will sometimes see that. Adverse effects, abnormal liver function, and liver failure. These are, whenever you are going to be put on a statin, you really should have a liver profile done to make sure that there's no underlying diseases there and that the liver is healthy before you start. And then they should do follow-up liver tests to make sure that this medicine's not affecting you negatively, because there is potential there for some liver damage. So whenever you see statin, think liver, and just kind of keep an eye on that. It's not like we're doing liver function tests every week or every month or anything, but normally they should be done prior to starting, and then some months later, 3 to 6 months later, they usually do another one, and then maybe every year after that. It would just depend on the doc and what their thought process is with that. Some other potential adverse effects, myopathy and rhabdomyolysis. What happens are we can have some wasting of the muscles with these, and that breakdown can cause backup basically in the kidneys. Kidneys can't process it, so it causes rhabdomyolysis. Most common symptoms of this or adverse effects. So those are the big adverse effects, the things we're definitely going to watch out for. Honestly, they're usually fairly well tolerated. Some people, though, do complain of a little bit of nausea, especially in the beginning. Actually, and they may complain of a little increased flatulence, potentially some constipation. Those are the more common adverse effects. But we want to really watch out for that. Want to watch that liver function test, and then educate them to tell us if they start having any muscle aches after taking these medicines. Be contraindicated in pregnancy and breastfeeding, and then of course active liver disease. If you have active liver disease, not a good idea to take these medicines because they can negatively affect the liver. Patient teaching. Take with evening meal or at bedtime. Now, there are statins nowadays that they approve to be taken during the day. I think atorvastatin is one of them. Atorvastatin's now pretty common. Simvastatin still seems to be the most common of the statins. But atorvastatin, I believe they say you can take during the day. What really this means to you is ask your patient before you give them the medicine. I have multiple times at a hospital where some hospitals, they, for whatever reason, they always schedule these during the 9 a.m. Medication pass. So I always ask the patient, when do you normally take these at home? And honestly, I bet 70% of them say, oh, I always take that one at night. So I just change it to night. I call the pharmacy, say, hey, this person normally takes this at night. Can we just reschedule this for their normal time? That way, when they go home, they can continue taking it at their normal time. That's really, and then of course with the patient teaching, if the provider says it's best to take it at night, then we'll teach them about that. The reason why that is because that is when our body is processing these, the lipids and everything, so that it just helps with that. And then of course we're going to teach them that they're going to need to do follow-up appointments, to have labs drawn for cholesterol and liver function periodically. So we'll just let them know that, let them know when the next appointment is, depending on whenever the doc says they want to see them again. So again, that's statin. Statin's most common cholesterol medication. When you see statin, think liver, and then also muscle aches. We could put that in patient teaching as well. Notify us if you start noticing any muscle aches. Ezetimibe, I still see it from time to time. Not as common as when it first came out. It works in the small intestine. That's how this one's going to work, and it helps inhibit the absorption of cholesterol. So the cholesterol that we actually intake. Our bodies make cholesterol on their own. Some medicines deal with that. This is one of the medicines that actually deals with dietary cholesterol to help inhibit the absorption of that. So our indication is high cholesterol. That's why we would take that. Our adverse effects for this medicine is hepatitis, again, so liver disease, liver problems, and myopathy. So just like a statin, really any cholesterol medication, or a lot of them anyways, can affect the liver. Anytime I'm looking at cholesterol medicine, I want to make sure that the patient doesn't have liver disease, and if they do, that the doc has determined that obviously the benefits are still outweighing the risk. So I may have to have a quick talk with them just to make sure we're all on the same page. And then again, myopathy with this one as well. The more common adverse effects, though, again, nausea, maybe a little abdominal cramping. This one may cause a little diarrhea, because if we look at it as inhibiting the absorption of dietary cholesterol, that means it's going to come out, right? That cholesterol is still going to come out of us. That may make our stools a little looser. That does occur with this. Those are the more common adverse effects, but we really want to watch out for that potential for liver damage and myopathy. Patient teaching with this medicine, it can interact with other lipid-lowering agents. So we want to teach them about that. You know, if a doctor prescribes you to be put on a statin with this, make sure that they understand that you're on a statin, because these can sometimes, when you put these with a statin, it'll sometimes increase their risk for the myopathy and the liver damage. With this, they'll also need their periodic blood drawn, you know, to look for cholesterol and liver function. Of course, same as the statin, notified provider of muscle aches. With all of these meds, we want to make sure that we're educating them on lifestyle changes. You know, stop smoking, increase exercise, low-fat diet, all of those things. That does help. So we'll want to make sure we do that with all of these cholesterol medicines. Fibrates. This is the one I was alluded to earlier as far as triglycerides. These work with lipoproteins as well, but they're really good at triglycerides. They're the most effective anyways at reducing triglycerides. Gemfibrozil and fenofibrate, both common. Fenofibric acid, fine. All of these are common. I've seen them given. And that's how they work. They inhibit synthesis of lipoproteins and triglycerides. And like I said, triglycerides they're at least more effective at that. So that's their primary indication, hypertriglycerides. And then they can also help with that hyperlipidemia as well. So those are the reasons why we take them. Adverse effects. We're back to that liver damage and myopathy again with these meds. There's a potential there for that. More commonly, though, it's going to be the GI distress, again, the nausea and maybe some slight abdominal cramping. These also have been associated potentially with gallstone formation, so we'll just kind of keep an eye on that. If they have active gallbladder disease, they wouldn't want to take these. That'd be a contraindication. Of course, if they have liver disease already, then we wouldn't want to give them those either. That'd be a contraindication. And then anyone with renal impairment, we would be careful with that, because we want that could affect their clearance. Interactions, other cholesterol medicines. So being on these and a statin at the same time may increase our risk for liver damage and myopathy. Not saying you're never going to see it, but just saying you're going to be real careful with that. Bile acid sequestrants, the same. They can potentially interact there. These also may interact with warfarin. Patient teaching. These we normally take about 30 minutes before a meal, so we'll teach them about that. We'll teach them to notify us again if they start noticing muscle aches. And then, of course, again, they'll need to know that they have follow-up blood work for cholesterol and liver function, and when that is, you know, when they need to do their follow-up exams. Nicotinic acid, this is just vitamin B3. However, the prescribed amount is far higher than what normally you're going to find on the, you know, on the vitamin, in the vitamin aisle. I'm sorry, at the grocery store. You can get this in the vitamin aisle. But normally it's a much higher dose that they prescribed. Anyways, the prescription dose is usually higher. The way these work is they inhibit fatty acids from adipose tissue and increases the rate of triglyceride removal. So what that does is it helps reduce our LDLs and triglycerides. So we take them for hypercholesterol and hypertriglycerides. These you can usually see an effect within 5 to 7 days, and it takes about 3 to 5 weeks though to see a maximum effect, so it takes them a little bit. The other ones take a little bit as well, though. It's not like you get immediate benefits from the others either. Adverse effects. The most common adverse effect with this is flushing. does occur. You will find B3 in a lot of energy drinks, and you'll see people that complain that sometimes they'll have facial flushing. They'll get that redness there with the after they take those or drink those or whatever. Same here. It's that vitamin B3 just sometimes can cause that. Other adverse effects, these can still, in the dosages that they give for cholesterol, can potentially cause some liver damage. So we'll be concerned with that. And these can also increase our uric acid. So if you have gout, we'd want to be real careful with those guys. Be contraindicated in liver disease because we could potentially still cause some of that liver problem. And then, of course, be really careful with gout. Interactions. The other cholesterol-lowering medications, potentially, again, for that compounded liver involvement. Statins, that's a cholesterol medicine. We'd be careful with those. Patient teaching. Again, that facial flushing is, it's not only is it, I mean, it's a likely adverse effect. It's not like one of those adverse effects that some people get. It's fairly likely, especially with the dosages that they give you for cholesterol. So what they can do is they can take aspirin as long as it's advisable by the doctor. They'd want to talk to the doctor and make sure that they're safe to take that. Usually about 30 minutes before taking your B3 or your nicotinic acid, and that can help with that facial flushing. If they're diabetic, it could potentially affect blood sugar, so they may want to watch that a little closer. This can potentially cause the blood sugars to go up, so they may want to do a little closer monitoring. So if you're sending someone home with new order for vitamin B3 and they're diabetic, we would want to teach them to watch their blood sugars a little closer. And then, of course, let them know, yes, you can get this over the counter, but the prescribed dose is normally much higher than the dose that you get over the counter. Oh, I'm sorry, I did the patient teaching on that last slide, but I just did all that again. It's going to cause that facial flushing, so you can take aspirin 30 minutes before the dose to prevent that. Monitor blood sugars a little closer if you're diabetic. It's a much larger dose than the vitamin supplement. All right, so those are our cholesterol medications. We're going to talk about blood coagulation. Thrombolytics, again, very common medicine. You give these, if you work in a hospital, you'll give them every day. We put people on these in the hospital that don't have coagulating problems or anything because they're at risk for these, for clots, because of the fact that they're just sedentary. They're stressed, their body is stressed because of the illness, and the effects of that illness also potentially can increase their risk for embolism. So we put them on preventative or thrombolytic medications. Let's go to the next slide. Antiplatelets, very common thrombolytic medication. You'll see these quite often in the hospital. These aren't one of those preventive in the hospital, though. The preventive in the hospital is normally an injectable. These are ones that people are on long term. What they do is they just help keep the platelets from adhering to each other and causing that platelet plug. If we can decrease that, we can decrease the risk of potential clots. Aspirin is by far the most common, although you may see clopidogrel, especially if you work neuro. I've seen clopidogrel mostly in my neuro patients. There's others as well, but these are the two most common. Aspirin is far and away the most common that we give for antiplatelet. In fact, nowadays, aspirin back in the day was mostly fever and pain. Nowadays, it's primarily given for this exact reason. This is the primary reason we give aspirin. It's the primary reason you'll give it. You'll still give it sometimes in patients for RA and things, but as the most common reason is going to be antiplatelet. And so that's our indication. Prevention, it's cardioprotective. We're using it for its cardioprotective properties to prevent MI, TIA, strokes, or CVA, whatever you want to call it. Those are the primary indications now. Aspirin. Adverse effects. Well, if we're giving it to help decrease platelet formation, platelet aggregation, decrease clotting, we can increase the risk for bleeding. So bleeding, of course, would be an adverse effect. Most common adverse effect with this medicine is GI distress. In fact, it can, if taken too often and too much, we can increase the risk for peptic ulcers. But GI distress is the most common adverse effect. This can also cause thrombocytopenia, so we may want to look at those platelets before we give it. Be contraindicated if they have thrombocytopenia. So if platelets are less than 100,000, I'd probably at least talk to the doctor before I gave it. And then of course if they already have bleeding disorders. Now, surgery could be a contraindication depending on the type of surgery, what procedure is being done. Normally the doc will say, okay, you got to stop this so many days before, and then you can start it back up so many days after. So if you know that they're going for surgery and they have aspirin ordered, ask the doctor. There's sometimes when they're like, no, aspirin's fine for this procedure, and sometimes when it's no, absolutely not. And then be careful in anyone that's had recent surgery. Again, know when that needs to be restarted. Also, if they have a closed head injury, we don't want to encourage bleeding there. So that would be we'd probably be contraindicated in that. We would just, again, talk with that doctor, make sure that everyone's on the same page. As far as interactions are concerned, any other drug that affects blood clotting. So these could potentially interact with warfarin, potentially interact with heparin, because we may potentiate further bleeding. That said, you will commonly see these given with warfarin or with other thrombolytic medications. But just know what that means is you've got to watch them a little closer. You need to teach them about the signs and symptoms of bleeding and all that, and watch that a little closer. Patient teaching. So let's teach them about the signs of bleeding. If they start noticing black tarry stools or, bleeding gums, if they start, they could even notice some abdominal distension, right? That can occur. If the stools were like a maroon color or kind of bloody looking, of course, that would be more of a lower GI thing, but we'd still be concerned about that. Any signs of, bruising, right? Easy bruising, and you're on aspirin, that could be a problem. So that could be a sign of bleeding. Teach them also, it may cause GI upset. In fact, it's fairly common for it to cause GI upset, so it's okay to take these with food. Most people find that taking it with a little bit of food helps with that GI upset. If you want to tell them to notify providers. Any provider that they have, make sure they understand they're on aspirin, especially if they're going to send them for a procedure. They certainly need to know they're on aspirin so that they can come up with a plan for when to stop it and when to start it back up again. So that's any procedure. And then sometimes we do take these in combination with the other anticoagulant medications, and we'll just teach them to now be even more alert to those signs of bleeding. All right, so parenteral anticoagulants, these are the injectables, heparin and enoxaparin being the most common. There are other parenteral anticoagulants, but obviously the most common ones we give are heparin and enoxaparin. These work by affecting the clotting cascade further down. These are towards the bottom of the clotting cascade. If you've taken an advanced physio, you have probably had some familiarity with the clotting cascade. I don't expect you to know the clotting cascade as far as like all the factors and how they interact and all that. It's a major process. Good for you for taking advanced physio and getting through that, but I don't expect you to have to remember all of that. But I do like to talk about it a little bit with these medicines because it helps you visualize where this is being affected, and that helps us understand the labs that we use for these meds, and it also helps us understand why sometimes we can give them together and still be safe. Certainly when they're given together, we know we have to be careful, and we wouldn't encourage the patient to take some of these together without talking to your doctor, right? So we wouldn't encourage them to take aspirin while they're at home if they're also on enoxaparin, unless they talk to their doctor first. But understanding where these fall on the cascade helps. We'll talk about this a little bit in lecture, and we'll go over the cascade. We're not going to go in great detail, and you will not be tested on levels of the cascade. I only do this so you can visualize it a little bit, to kind of help you paint that picture of where these things work. This is the heparin's the one that works furthest down. It works down towards the factor 10 or X, whatever you want to call it, 10A, and the thromboplastin, right? That area there. So the test that we use for this is the partial thromboplastin time, right? The PTT, so the partial thromboplastin time. That's the test we use for heparin. Now, saying that, that doesn't mean that everybody on heparin is getting a PTT. In fact, when these are given a sub-Q, it's very rare we do a PTT. We give heparin or enoxaparin to almost everyone that comes in the hospital, right? When we go in the hospital, we're at higher risk for clotting because, well, we're not moving as much. We're sick, our bodies are under stress, so that increases the risk, right? There's other risks factors as well, especially depending on what's going on with the patient. So a lot of people, I won't say everyone, but by gosh, most of them are on some sort of anticoagulant medication, and it's usually heparin or enoxaparin sub-Q. It's really well tolerated. It's short half-life, so when they leave, you know, they're fine. It'll be out of their system fairly quickly. So we give them this. And then we use it for other reasons as far as anticoagulation goes as well. But when it's given sub-Q, you don't really care about the PTT so much. When it's given IV, which would be heparin, heparin's the one that you give IV, now we care about the PTT or the APTT, which is your active PTT. But again, don't get too crazy about that. Just know PTT, the partial thromboplastin time, is what we use to check heparin. And the reason why I'm really making sure to highlight that, the PTT, is because people get that confused with the warfarin test, which is PT, prothrombin time. We'll get to that later. But don't confuse those two. So PT, INR, that is warfarin. It's primarily INR, but you'll always hear them say PT INR. And people get that PT confused with the PTT of heparin. So don't let that explode your head. Just keep PTT. If you see two T's, that's heparin, PTT, and that's primarily IV. Not to say you won't see it with sub-Q. If we were concerned that they got too much sub-Q medication, we would probably do it. Or if they had certain risk factors, the doc would probably do it before we started the sub-Q. That does happen. But normally, they just give the sub-Q because it's fairly well tolerated. That said, there is definitely a lab that we will do for heparin and enoxaparin, or that we will check anyways. And we'll talk about that here in a second. But if it's IV, it has to be the PTT. We have to check that. Okay. So again, action works on that factor 10, 10A, thromboplastin, fibrinogen, that area there. It's further down the line. And our indications is prevention of clotting for people that are at risk, or sometimes we use them for people that currently have a clot to help with that. Help first keep the blood flowing around it, and to help with that clot. So that's usually when you're given IV heparin, is in those circumstances. Adverse effects. Bleeding, obviously, #1 adverse effect. I mean, we're giving it to help technically thin the blood, so bleeding. Bruising at the injection site does occur, so let's make sure we hold that in to their, so we're gonna give it to them in the belly, 2 inches away from the belly button. When we do that, we hold that for, your book tells you 10 seconds in order to keep that med in there and not coming out. When that med comes out, that increases the risk for bruising. Not saying that they won't get bruising by you holding it in for doing that, holding it in. That'll absolutely keep them from bruising. It's just one of those ways to kind of help with that. It also helps with some of the burning. But just watch for bruising at the injection site. It's actually common, but just watch for it. Contraindication, another adverse effect that goes along with your contraindication is thrombocytopenia. That's another adverse effect, and that is the other lab we're going to check. So again, when it's sub-Q, we don't always get a PTT. In fact, it's rare that we get a PTT with sub-Q injection, but we definitely check platelets. So check platelets. If you are giving heparin, there's a couple things we got to, or enoxaparin, either of those, a couple things we got to think about with platelets. We're worried about thrombocytopenia. If you look at your book, or even at the hospital, you look at what the lab considers normal. They consider usually 150 to like 350 or so to be normal, right? So the bottom line is greater than 150, and that's good. With heparin, though, we're really looking at greater than 100,000. So if it's greater than, if you look at the platelets, and they're on heparin or enoxaparin, so we know we have to look at platelets, and they're greater than 100,000, now we need to think of something else. There's part 2 to that. If they're less than 100,000, we just stop right there. We do not give them the heparin or enoxaparin. We call the doctor and say, hey doc, what do you want to do with this? And she'll either make adjustments. She'll probably tell us to hold it and maybe try warfarin or whatever she decides to do is fine. But we're going to make sure we're being safe. They may give you a good explanation. Usually if it's less than 100,000, it needs to be held. So you just stop it. You do not give that. So you're going to check platelets. Oh goodness, it's less than 100,000. Okay, I better stop and not give this heparin and call the doc and see what they want to do. In the enoxaparin, same way. If it's less than 100,000, you don't give the enoxaparin. If it's greater than 100,000, great. It's still not considered safe yet. We got one more thing we have to consider with those platelets. So let's say we check and the platelets are 160,000, which is obviously better than 100,000. It's even better than 150,000, so it seems pretty safe, like it would be all right to give this medicine. However, what we need to do is go back to when they started the heparin. So if they've been on this heparin, if it says, they've been on this heparin for 4 days, I'm going to go back 4 days, and I'm going to look and see what their heparin has been running, right? I want to know what it was when they started it and where they've been at. If it has dropped by greater than 50% from the time they started the heparin, we stop. We don't give the heparin or the enoxaparin, and we call the doc. So again, that 160,000 may be cool. Let's say they came in, it was 220,000, obviously not anywhere near 50% drop, so we're cool to give it at 160. But what if this other patient, okay, so we're going to give this other patient 160,000, and when they came in, they were at 400,000. Obviously a much greater drop than 50%. We would stop that heparin, we would not give it, and we would call the doc and say, hey man, just letting you know, so-and-so, platelets today were 160. We started this heparin 5 days ago or 4 days ago, whatever, and it was 400,000 at that time. It's greater drop than 50%. And then they'll give you rationale for whether they want to continue or stop it, and you'll make sure you make all note to that and that it's okay. You'll also obviously check for bleeding. You'll all be doing all those assessments as well. If and I've run into this, I've seen this in my patients before, where I've had to call the doc and let them know. And then I've seen that in a clinical patient where the client had a greater than 50% drop. They went from I can't remember the exact numbers, but they were above 100. They were like 125, 130, so not 150, but they were definitely above 100. But they had dropped significantly from the 5 days prior when they started the heparin. It was far more than a 50% drop, and so the nurse who had asked us to do the injection, I was just made sure I let her know, like, thank you so much for letting us do this injection. We're not we don't feel comfortable giving this medication with this drop. We're concerned about this. And the nurse actually never had heard of that, evidently, which was interesting. Didn't think that was their protocol, but when I looked it up, it was absolutely the protocol. There's no question that was the protocol. So the nurse held it, didn't give it, and said, oh, well, I'll go ahead and check with the doctor. Well, she didn't even get a chance to check. The doc came in, did his assessment, and wrote the orders, and the orders specifically stated stop the heparin, or I think it was enoxaparin, potential thrombocytopenia, continue with the warfarin as scheduled. So that made it made all the sense in the world, because it was a pretty significant drop. And so just keep that in mind. Anytime that someone's on heparin or enoxaparin, they need to we need to check their platelets and see where they're at. And then if they're on IV, we need to check PTT. As far as patient teaching, we're looking for signs of bleeding. So don't take, so watch out for that, the black tarry stools. Of course, if they're vomiting or coughing up blood, or, even they could have fresh blood in their stools. Any sign of bleeding, bruising, easy bruising, anything like that, bleeding gums, watch out for that stuff. We'll teach them about all that. Don't take NSAIDs or aspirin without talking to your doctor, right? It's normally they just tell you not to, but every once in a while they'll still say it's okay. Just depends. Like, again, don't take them. Talk to your doctor. They're going to need lab work, especially if they're on IV. Now, if they're on IV, they're not at home. They're in the hospital. But you're going to teach them about that, because they're going to probably get annoyed with you sticking them so often. But it's for their own good. It's for their protection, because heparin IV is far more potent. It can become over or hyper anticoagulated real quickly. So we watch that very closely. When you start heparin, before you ever start it, you usually have to, you always have to get a PTT. You got to get that PTT level and see what that is before you ever start the heparin. So you need to lay eyes on the PTT levels prior to starting the heparin. And some protocols will even go off of that. They'll also go off of weight, whatever the doc writes. There's usually a protocol, but the docs can augment those a little bit. So whatever the doctor writes for the order, then you'll start it, so long as that PTT is within a good range. And then you will make adjustments based on follow-up PTT levels. And usually it's like 2 to 4 hours later that you have to get another PTT. And you have to do that usually about every 4 hours or so, until they get so many PTTs in a row that are therapeutic, and then you go to like 6 hours. Again, don't take this as gospel, because there's different protocols, but just know you make sure you have that protocol in front of you, and that you are that you're utilizing that with your patient. Make sure before you ever take a patient that is on a heparin protocol, if you're getting report, that they've had their PTTs drawn appropriately, and that you know where they stand, and that adjustments have been made appropriately. The reason why I say that is because there's nothing worse than taking over a patient. They say, oh, they're on heparin, their last PTT was this, and then you go and you look, yeah, that was their last PTT, but that was like 12 or 24 hours ago, and they should have had another one, 6 hours prior or whatever. There's, they've missed some. And then you go check it, and by gosh, it's way high. And now you're chasing that, so the patient's at risk. Now you have to deal with this at-risk patient, and you're chasing that PTT. You're making the adjustments. So I make sure that that's all settled, because, if it's not, that nurse who messed that up is going to have to settle that. you know, I certainly will take over their care and help them with all that, but I'm going to expect that nurse to help me with getting that settled. So you'll teach them about that. Look, there's going to be multiple labs drawn, unfortunately, because of the risk of IV heparin, and it's for their own protection. But you will certainly have patients that are very upset about the number of lab draws you got to do. But depending on how their body reacts to it, I mean, you may be doing lab draws every 4 hours the entire time they're on it, 'cause they're just real labile. I've had that where, you know, they get hyperanticoagulated, and so normally when they get hyperanticoagulated, you don't have to go to the antidote. The antidote is protamine sulfate. You don't normally have to do that. Normally, I've never ever had to use it. I just stop the heparin, and it's got a short half-life, and within so many hours you start it back up, depending on the protocol, depending on the level of PTT. So just follow your protocols, and then you'll start it at a lower rate, and then you'll check the PTT again in so many hours. But I've had patients where they get hyper anticoagulated, so you follow the protocol, you turn it off, you turn it back on at a lower rate, and then you check it again, and by gosh, now they're low, and so now we got to adjust. I mean, I'm adjusting it all the time. So anytime you got a patient on heparin protocol, IV heparin, make sure you got that protocol in front of you, and you are religious about knowing exactly when I need the next PTT, and then exactly what I need to do based on those results. You can do this. People on med-surg are on heparin protocol quite often, especially if you work in a neuro unit. You'll have them all the time. You'll become very familiar with it at that point. But so it's not like something that has to be ICU or PCU. So you may very well get that even no matter what unit you work. But just know that. Just know, man, I need to know what the protocol is. I need to have it in front of me at all times. All right, oral anticoagulants. The traditional one is warfarin. There's others as well. There's some newer ones, apixaban, dabigatran, which are known as Eliquis and Pradaxa. Those are great. You will see them used far more now than they were when they first came in, because that's just the way, you know, the nature of things. They're expensive. So not all insurance companies are gonna approve it, whereas warfarin, very, very, very cheap medicine. And apixaban and dabigatran, they're not always indicated. There's still potential clotting disorders and things that warfarin's still the gold standard for. So it's not like everyone can be on those, but they're definitely becoming more and more used because there's not as much lab testing involved. Warfarin, tons of lab testing. We're testing them all the time, especially in the beginning. Apixaban, not necessarily. So the action, these work on, especially warfarin. The warfarin works in the clotting cascade at the vitamin K enzymes, or the liver enzymes, or I'm sorry, the factors, the liver factors, the vitamin K factors. And that's like your 5, your 7, your 9. There's others, but those are the 3 that I think of primarily. That's further up the cascade than where than heparin and enoxaparin. Enoxaparin and heparin work down the cascade. These work up higher in the cascade. There's some things, knowing that it's the vitamin K and the liver factors also helps us understand warfarin a little bit. Indications, again, any prevention of thrombus, or patients that have a risk for thrombus, like patients with AFib, right? If you have AFib, you have a risk for thrombus formation. Not every patient with AFib is on warfarin, but every patient with AFib is on some sort of anticoagulant, whether it's clopidogrel, aspirin, warfarin, apixaban. They're on some sort of oral anticoagulant. And then those are basic indications. The prevention of thrombus for whatever reason. They could have a disorder that causes them to need it. They could have had a history of multiple strokes or MI, and the docs decided that we need to start anticoagulating them to help decrease that risk. For whatever it is, some sort of risk for thrombus, that's why they're taking it. Adverse effects, number one obviously is bleeding, easy bruising. Those are the things you're looking for. However, warfarin is also a narrow therapeutic range medication, which tells us that there's a potential for toxicity. Normal therapeutic range is 2 to 3. When you start getting above 3, it needs to be stopped or at least decreased significantly. It's got that long half-life, so we're worried about that. If it gets above 5, we'll really start worrying about it. You may even have to do the antidote. Now, it affects the vitamin K factors, so your antidote is vitamin K. You give vitamin K, that helps to it helps against warfarin toxicity. And I've definitely given vitamin K before for warfarin toxicity because, again, it's got a short half-life. Or I'm sorry, I apologize. It's got the long half-life. Apologize for that. Warfarin has the long half-life. So it's not as simple as heparin where you just stop it, right? With this one, if they're hyper anticoagulated, they're at risk for bleeding. They're going to stay that way for a longer time. So we need an antidote, and the antidote, luckily, is pretty easy. It's vitamin K. Contraindications. Obviously, active bleeding. Also, severe liver disease. If you have severe liver disease, or you got a patient with severe liver disease, they're normally checking INR on those because their INR is affected. Their clotting factors are affected because the liver is responsible for some of those clotting factors. So sometimes you'll see an INR drawn on someone that doesn't have an anticoagulant on board, and it's because they're probably checking for liver activity. And then also pregnancy. You would be contraindicated in pregnancy. You'd be really careful with any surgeries. I would not give it until I know what's the doctor's rationale for when to stop and when to restart the warfarin if the patient's going for surgery. I need to know that before I give the warfarin. And then, of course, if they're at high risk for bleeding for any other reason. So any sort of procedure or surgery, I'm not going to give it until I know what the doc's thinking as far as when they should start and stop and all that, or stop and start it. Interactions, any other blood clotting medication. That's not to say you won't see people on warfarin and aspirin at the same time. You will certainly see people on warfarin and heparin at the same time for short periods of time. The reason why is because that is they use it as a bridge. So again, we talked about warfarin having a long half-life, heparin having a short half-life. And then if we think back to what we've learned about the cascade, heparin works further down the cascade, warfarin works further up the cascade. So they work at different levels of the cascade, and one of them has a long half-life, one of them has a short half-life. You use these to bridge. So let's say the person's being anticoagulated on heparin or enoxaparin, and the docs decide they need long-term anticoagulation. They're not going to keep them on those medicines for long because nobody wants to sit there and shoot themselves in the stomach all the time when they could take a pill. So they'll put them on normally warfarin. The problem with warfarin is the potential for toxicity, so we've got to watch our levels. And the other problem is it's a long half-life. So we've got them on heparin right now, and they're at a therapeutic level being anticoagulated. The warfarin's going to take 2 to 5 days because that's what our normal half-life is, right? It could take 2 to 5 days to get that under control, and sometimes even longer to become therapeutic. If we were to stop the heparin once we started the warfarin, there would be those 2 to 5, maybe even longer days where they're at risk because they're sub-therapeutic. So we need to bridge that. In order to bridge that, we keep them on the heparin or the enoxaparin until they become therapeutic. Now, they still may go home. They'll just go home on heparin or enoxaparin, and they'll have to know how to give themselves that while they wait for that warfarin to to kick in. So we'll educate them on that, how to give it, and or I'm sorry, that we'll educate them on how to give, obviously, their enoxaparin, but also why they're taking the warfarin with it, and that they need to make sure they're doing the follow-up test to keep their INR at whatever level the doc says he wants it. Normally that's between 2 and 3. Every once in a while you're going to see what's called hyperanticoagulation, and that just means the patient or the doc wants them to be a little above 3, not normally much above 3, because then we can get into some risk factors. But interaction, so again, any drugs that affect blood clotting, but again, you will still see those given, and we just talked about why. But we would certainly educate them not to take any meds like aspirin or NSAIDs without talking to your doctor first. It actually interacts with a lot of other meds because of the potential for a lot of meds are run through the liver, right? The liver affects a lot of medications. This is one. Warfarin is one of the classic ones, and those meds can potentially interact with each other. So there's other meds as well, when we've learned about a lot of those. Another thing, though, that common interaction that we definitely need to educate on is vitamin K. So foods high in vitamin K can affect the effectiveness of warfarin. If you're eating too much vitamin K or foods, you can affect how well the warfarin is working. Or if you're used to eating a lot of them and then you just decide not to eat them anymore, the warfarin may work too good. So we'll need to educate them on that. Your foods high in vitamin K are your green leafy vegetables, spinach, kale, broccoli, those types of things. I'm going to tell you now that green beans are not green leafy vegetables, and I've seen that question on tests like ATI and NCLEX, like big tests, where they try to throw you with green beans. Don't let them throw you. That's not a green leafy vegetable. Broccoli, however, is a green leafy vegetable. So patient teaching. If they're going to eat vitamin K foods, which they should because they're good for you, but they need to keep it consistent. Don't go on a broccoli binge thinking because you read an article about how broccoli can potentially stave off certain types of cancers or whatever. Fine. If you're going to do that, though, become a broccoli connoisseur, you need to let your doctor know, and you need to watch your INR level closer while you, increase your broccoli intake, because there may need to be some adjustments made. The same goes the other way if you've eaten spinach salad, if you're Popeye, okay, and you eat a can of spinach every day, because, well, you must hate yourself because canned spinach is horrible. But whatever, whatever. We've all got our own thing. If you eat that every day and then you decide, I don't really like spinach anymore, and you just stop, you need to let your doctor know, because you can put yourself at risk for, again, hyperanticoagulation. So keep your vitamin K consistent. Vitamin K intake needs to stay consistent, and if it's not going to stay consistent for whatever reason, you need to let your doctor know. Of course, educate them on signs of bleeding. Don't take NSAIDs or aspirins without talking to your doctor. And we're going to educate them on lab work. The lab work is pretty significant, especially in the beginning. Once we get their INR stabilized, then they can have less regular lab work. But in the beginning, they're probably getting lab work every day. Now, there is a machine that you can do it on your finger, a finger stick INR machine. It's pretty expensive. It's definitely better than it used to be as far as expense goes. It's a little more affordable, but it's not nearly as affordable as the glucose monitors. But that said, they'll need to check it every day, no matter however it's being checked. If the nurse is coming out and doing the bloods, the finger stick, or a peripheral stick, or they have to go to a clinic, whatever it is, we're going to make sure we educate them on how, when to get those labs done. We'll tell them to avoid activities that increase the risk of bleeding. Okay, so high impact sports is not a good idea. And then, of course, notify all providers that you're on heparin, because one, they have to worry about certain medications, and two, if they send them for any sort of procedure or surgery, they definitely need to know they're on warfarin to tell them when it's safe to stop it, what to do between stopping it and the surgery, and then when it's safe to start it back up again.